All right. So Mike was talking to you about the importance of making a diagnosis. And endoscopic ultrasound is definitely one of the best options to be able to get fine needle aspiration, to get tissue for the surgeon and actually see if the vessels are involved or not. But sometimes you have those patients that are like in borderline. The duct is dilated, you don't know if there's cancer, there's no cancer, and you really try to get a better way to get a diagnosis. So this is a patient that actually has a premalignant lesion called intraductal papillary mucinous neoplasia. And the duct is dilated, and we know that there is lesion inside the duct. So our job is to tell Mike, well, you only need to resect this part of the duct. So we went inside the duct with like a little scope, and we are looking inside the scope until we found those little villus lesions. You see this? And we know that this is where the cancer is going to be. So this is specifically into the head of the pancreas. That will allow Mike to preserve actually the tail of the pancreas. So what I'm going to do here, I'm going to slide out from this area, and this actually lesion is communicating with a big cyst. And I'm actually here into a cyst looking at this area, which is part of this abnormal lesion. So here I am with a little camera doing what we call a pancreaticoscopy to make a diagnosis. And I'm going to take it to the next level. I'm going to actually get into the cellular level. And I have a mini probe that allows us to actually, if you touch a lesion anywhere into the GI tract, you can assess if you're dealing with a cancerous lesion or not. So in this case, with the mini probe, I'm going to put myself against those villus lesions. And I'm going to have live endomicroscopy. So not only I'm going to make a biopsy and then send it to the pathologist, but I'm also going to live assess those lesions. You see, I have like a microscope that is combined with my scope that will allow me to look at those villus lesions. So we have some very interesting data about this that just got accepted today actually into digestive and liver disease. The combined data from Weill Cornell and data from Marseille, France, a great team of Marc Giovannini. So this actually will be published pretty soon and available to the public, showing that this permits to do early diagnosis and mapping for people that have pancreatic cancer. So this is echoendoscopy, and as you can see, we can reach anywhere into the pancreas. The tail of the pancreas, the body of the pancreas, the head of the pancreas. We can get those lymph nodes, we can get those lesions in the liver. All this we can reach them and get a biopsy, which is very important for the surgeon. But echoendoscopy has taken a new turn. It has become more and more therapeutic. So what can we do? We can do blocks. This is very important for those people that have pancreatic cancer and have pain. They cannot get surgery, they cannot get relief with chemoradiation, but they have pain. Well, we can give them a block. We can go with a needle and inject the nerve of the pancreas and get rid of this pain, and so they can eat again and feel better. We can drain collection, like we talk, post-surgery, for instance. And we can do also what we call EOS-guided procedure. So we combine echoendoscopy to our ability to do ERCP or other complex procedure to treat those patients. So we started by fluid collection. So this is one of those patients that had surgery, and you see there's a big abscess here. And so what you're going to do, you're going to puncture here by echoendoscopy, dilate, and then place 2 pigtails, and this is it. It's gone. The abscess is gone. So all this from the inside can be done. So no more drain from the outside that can hurt the patient, give him skin infection, give him a scar, and really make his life a misery. There's no need for this anymore because we can do all this from the inside. So what about those patients that you want to drain? Yes, you can do an ERCP with a scope, but sometimes you can get down to the second portion of the small bowel. So in those patients, we can actually drain directly from the stomach. So what I'm going to do here, I can see where are the ducts into the biliary tree that are dilated. And I'm working from the stomach, so the stomach is here. So here I am looking at those ducts. You can see where the vessels are. So that's going to be my ability to avoid those vessels. Now I know where they are. So here I am, I'm going to stick a needle very gently into those dilated ducts, and I'm going to inject contrast. You see I'm filling the biliary tree here from the stomach. You see no surgery, no drain from the skin. Everything is done completely from the inside. So I'm going to advance a wire now, and I'm working from the stomach using this as my roadmap, as my vision. You see, and I'm advancing the wire very gently. You can see this by endoscopy here. All this is a dilated bile duct due to cancer. This patient really need to be drained. And before, they used to go to interventional radiology and get a drain from the skin. Not anymore. Here we are dilating here, and then we're going to advance the balloon over that wire that I have, so I can get more contrast and define better the anatomy. You see how dilated the duct here? And you see I have a wire that is coiled. I'm going to play with the wire very gently, get that wire into the small bowel, and then I can measure the distance between the small bowel, which is here, and the bile duct, which is here. So I can then decide exactly how long of a stent I'm going to place so the patient can feel better, can be decompressed. So I'm going to do a balloon dilation. You see my scope in the stomach? All the way here, from the inside, here. You can advance the stent. You see? So I have replaced a procedure that used to be done through the skin, through the liver, by a procedure can be done entirely from the inside. So this patient actually, after that, his bilirubin came down, and he was able to receive more chemoradiation to shrink his tumor. So this is what we can do now. We can do all those things. Now, what about those patients that have tumor involved in the bile duct, and you really want to do some debulking? Well, we have new probe here that you can actually endoscopically place at the level of the cancer and induce some burning. Actually, we just got published our data a few months ago about this technique. And this is one of those patients with cancer into the bile duct. You see, with the same camera, I'm looking inside the bile duct. This is before treatment, and this is after treatment. Look at this, how burned this is. This is what we do. We're basically burning cancer from the inside. So we did a study that we got published a few months ago. We compare all the patients that get just a stent. And we compare them and get a stent and the burning. Well, the people that get the stent and the burning do better, live longer than the people that just get the stent. So we are now over the concept of just placing a stent and moving on. We're trying to treat from the inside, and this is very important to do. So we're trying to work with the FDA on a new probe, taking time. As you know, FDA can be very slow, where we can do this with endoscopic ultrasound. So just like we can drain things, we would like to actually, you see here, put a little probe by echo endoscopy and burn the pancreas. So this is actually a pig model that we use for the FDA, and the data is with the FDA. They analyze it, they have more questions about the probe, about us, about the pigs. I mean, it's like non-stop with them. And here it is, that famous pig. You can see that the burning is very focal, and that's exactly what we want. We want to be able to prove to the FDA how safe this is. We want to be able to prove them that we can localize the necrosis without inducing inflammation in the rest of the pancreas. So now, what about the future? Well, the future is to be able to provide relief in the symptom of the patient, okay, by doing what the surgeon used to do. Some of those patients cannot get surgery, and they have an obstruction of the bowel induced by cancer. So this is actually a video paper that Amy, my advanced fellow, just submitted and got accepted. And you're the very first one to see it before it's become public. What we're trying to do is a patient that had a stent between the stomach and the bowel, and the patient still is feeling obstructed. So she's very sick, she's pretty old, she's not a candidate for any surgery. But we need to create a connection between the stomach and the small bowel. How can we really do this, knowing that her stomach is humongously dilated, and knowing that the stent we place is doing nothing? So we really need to work into the back wall of the stomach. You see, we can get through the antral stent, but the stomach is completely dysfunctional, completely dilated, completely uncompliant. So what we're going to do here, we're going to advance the balloon through that stent that is not functioning here, and try to get that stent all the way into the bowel. This is all done by endoscopy. Once we have that balloon into the bowel, we're going to remove the scope. You see the balloon here with contrast, We're going to remove that scope, and we're going to go with the echo endoscope. This is the echo endoscope, the scope that can see through the wall, the same one I'm using to drain collection and do all those things. Look how well you can see the balloon. So here with the needle, we are puncturing the balloon filled with water and contrast, and we break the balloon. Why? Because we want to make sure we are in the right loop of bowel. the loop of bowel that we're going to use to create the connection. So you see I'm advancing a wire here. So now I have a wire that goes from the stomach into the bowel. I have a connection. So what I'm going to do now, I'm going to create a fistula. All this done from the inside. You see this? I have a little knife here. With cautery, I'm creating a fistula between the stomach and the bowel. All this done using just radiology and endoscopy. And this is a stent that's going to allow me to oppose the wall of the small bowel to the wall of the stomach. And here it is, deploying. I'm going to dilate, and just from the inside, I'll just have created a gastrojejunostomy. This is a procedure that used to be done surgically. This patient never saw the knife, never saw any kind of surgery. And a few days later, the patient went home. This is exactly what I'm talking about, providing relief to the patient with minimally invasive technology. And this is my team. This is Amy, my advanced fellow here with a beautiful smile. And this is my partner, Reem, and one of my other fellows, Jessica. Thank you for your attention.
Wow.
Happy to answer any question. I don't know if